Next up is Dr. Priyanka Wali. She's an internist who practices low-carb nutrition. And when I was at Low Carb Denver at Dr. Gerber's program, at Jeff's program, there were very few speakers who did as good as her. In fact, she hit the ball out of the park. So you are in for a very enlightening, entertaining, and educational session here with her. Priyanka?
You know, when I hit 50, my body went through a big change, and not for the better. Severe erectile dysfunction shattered my confidence, set me into a depression, and almost ruined my marriage. And believe me, I tried everything. But then a friend told me about Zentrex, so I tried it, and it worked.
Zentrex is the strongest male enhancement drug on the market. It increases blood flow, boosts testosterone, and ends erectile dysfunction instantly.
So I asked my doctor about Zentrex, and he said, Zentrex? What the hell is Zentrex? And I said, Zentrex. It's the strongest male enhancement drug in the world, and it works. And he said he'd never heard of it. So I pulled up the Zentrex website and showed it to him. He started laughing. He said, are you insane, man? You can't put that junk in your body. It'll kill you. Your heart will stop. Rhino horn, ammonia hydroxide, that's what's in meth, right?
Zentrex is made strong enough to work on the most extreme cases of erectile dysfunction. And fast.
My doctor asked me, where'd you even hear about that? And I told him, a friend. And he said, well, what's his name? And I said, well, I don't really know him, actually. And he says, but you just said he's your friend. So I told my doctor, look, let's just forget about him and just write me a script for Zentrex and I'll be on my way. My doctor said, are you deaf, man? No. I could lose my license. You could die. I said, yeah, I think I still want it though, so give it to me. Write the prescription. I wasn't leaving. So he says, I think that website just froze my computer. So I grab him a little. And he goes, you're hurting me, sir. Zentrex works.
Side effects of Zentrex include fits of rage, acne, bleeding, baldness, blindness, whooping cough, hallucinations, coma, trouble swallowing, decrease in semen, increase in semen, nasal sores, constipation, vomiting, night terrors, amnesia, and suicidal urges.
And those are just the side effects they tell you about. I get the sweats, my bones are cold, my teeth are loose, my heart gets really, really hot. I could read minds. And sometimes I wake up driving a stolen car. And my erections are fantastic. When I wear gray sweatpants, people cross the street, which is fine. Zentrex gave me my life back. Hail Satan.
So threaten your doctor or ask your ketamine guy about South African Zentrex today.
It works.
So, welcome everyone. I'm Dr. Priyanka Wali, and it is a real pleasure to talk on a subject that is very near and dear to my heart and my womb. And that's it. Thank you very much. So, I am giving this lecture because I believe there's an important connection between insulin resistance and sexual health, and I'd like to show you the data behind that. Simply put, you have to watch what you eat if you want to perform between the sheets. And the beauty of this is that this information is intended for medical professionals and civilians alike, because I believe everyone is entitled to a satisfying sex life, and it is the duty of the physician to help the patients foster that. You know what I'm talking about. So, today, in the next half hour, I hope to first describe the statistical data on the prevalence of sexual dysfunction on both men and women. And then I'm going to take some time to help you recognize that there is a correlation between metabolic syndrome and sexual dysfunction in both genders. Also, I'll spend some time exploring the correlation between infertility and insulin resistance. And finally, I hope that any physicians in the audience listening today will understand that any signs of sexual dysfunction in men and women should warrant screening for insulin resistance. So, full disclosure, I'm an internal medicine and obesity medicine physician in private practice in San Francisco, and I'm also Chief Medical Officer of Platejoy and Medical Director of Miro Health. So when I talk about sexual dysfunction, What exactly do I mean? So sexual dysfunction is defined as any disturbance in sexual desire and in the psychophysiologic changes associated with the sexual response cycle in both men and women. The sexual response cycle is a series of 4 physiologic phases that occur in both men and women during intercourse. So as you'll see here in the chart, the sexual response cycle, sex first starts with arousal, and then there is a excitement phase followed by a period of plateau, and then sex peaks with orgasm and then falls to resolution, after which you may smoke a cigarette or roll over and fall asleep, whatever. And some people who are carb addicted say they experience this same cycle as well when they're going off of carbohydrates. But now, I want to emphasize that I'm only going to talk about one aspect of sexual dysfunction, because sexual dysfunction is actually a multifactorial, multidimensional disorder. There are many possible causes. Many of the medications that we prescribe, like SSRIs and beta blockers, can impair sexual function. Any stress to the body, like a recent illness or surgery, can lead to sexual dysfunction. Psychological trauma plays a huge role in someone's ability to perform sexually. There are hormonal changes, like naturally occurring changes such as menopause, or the use of exogenous hormones like oral contraceptives. Now, I'm not an OBGYN, I am not a psychiatrist, I'm not a therapist, I'm just an internist. So I'm going to spend this time focusing on the impact of vascular dysfunction on sexual health. Now, before I reveal the data, I just want to emphasize that when it comes to sexuality studies, there are major issues. Most of the studies have been done only on heterosexual couples, white couples who come from middle to upper middle class socioeconomic backgrounds. And most of the studies focus on men and male sexual dysfunction. The studies in women are lagging far behind, and I don't know if it has something to do with the fact that there's a lot of societal taboos regarding female sexuality, or the fact that there's not very well validated definitions of what female sexual dysfunction is. But the data needs to be treated with caution. There's very few rigorous RCTs. Most of the data is observational. So let's just take it all with a grain of salt. Now, when looking at the prevalence of sexual dysfunction is highly prevalent in both sexes, but it's more common in women. In fact, worldwide, 40 to 50% of women have sexual dysfunction, and that's irrespective of age. For men, the numbers are lower, but age plays a greater role. As men age, their chance of sexual dysfunction goes up. And for men, the most common complaint is erectile dysfunction. So men are upset because they can't perform. For women, the most common complaint is low sexual desire. So women are upset not because they can't perform, they just don't want to. And what was also interesting is that married men and women have a lower risk for experiencing sexual symptoms compared to their non-married counterparts. And when I found that out, I thought that was very interesting. Is it because married couples tend to be partnered and they tend to be working together more on the issues, therefore less likely to suffer from the sexual issues? Or is it that married couples have just given up and they just stopped complaining and are lying to each other? So I don't know. I mean, it's something, there definitely needs to be more studies on that before you file the divorce papers. So anyways, let's get deep into where most of the research has been done. Erectile dysfunction. Can't get it up, can't keep it up. And as you saw by this commercial, the pharmaceutical male enhancement industry is a multi-million-dollar industry, and it's doing quite well and continues to do quite well. Because men are sold this idea that they can just take a pill, they can improve their odds of having an erection. But I'm here to tell you, sure, the odds are good, but the goods are still odd, because erectile dysfunction is a measure of cardiovascular disease. So this was data gathered from a National Health and Nutritional Examination survey. They surveyed about 20,000 men. And they asked these men, do you never have an erection, or do you sometimes only have an erection? And about 4,000 men responded, yeah, that's the case with me. They did have erectile dysfunction. So then they did a logistic regression analysis, and they looked at how many of those men had either undiagnosed diabetes, undiagnosed hypertension, or undiagnosed high cholesterol. And what they found was that there were a higher percentage of men with erectile dysfunction who had undiagnosed high blood pressure compared to those that didn't have erectile dysfunction, but after adjusting for confounders, that data wasn't statistically significant. For cholesterol, there was no statistical significance between having erectile dysfunction and having undiagnosed high cholesterol. With diabetes, however, erectile dysfunction was strongly associated with undiagnosed diabetes in both the adjusted and unadjusted analyses. In fact, the relationship was strongest for men in the age group of 40 to 59. They found that the predicted probability of having undiagnosed diabetes in someone who had erectile dysfunction went from 1 in 50 to 1 in 10 if they did have erectile dysfunction. So why does this happen? Well, it starts with obesity, specifically visceral obesity. Because visceral obesity actually does a double whammy to the penis by leading to both hormonal and inflammatory changes. So hormonally, adipose tissue contains aromatase, and aromatase converts testosterone to estradiol. So being obese, you will be in a high estrogen state, and there will be low testosterone thanks to aromatase. And obesity is also a pro-inflammatory state. So this would result in the increase of pro-inflammatory factors, which would then lead to direct vascular damage to penile tissue. So it's the combination of this vascular endothelial damage with the hormonal testosterone deficiency that leads to essentially a non-functioning penis. So this was a very dramatic study done at an Italian sexual dysfunction clinic. They took 803 white men who presented for the first time to this clinic with sexual dysfunction. And they could have complained of anything: erectile dysfunction, premature ejaculation, decreased libido, blue balls, you name it. And they found that about 30% of these men were diagnosed with metabolic syndrome, and practically all of them had erectile dysfunction. And then what's fascinating about this study is that they went on to do glucose parameters and hormonal levels, but they also did penile Doppler ultrasounds at baseline and 20 minutes after injecting their penises with prostaglandin E1 to induce an erection. So they measured baseline, peak, baseline blood flow velocity, and then peak blood flow velocity at 20 minutes. And this, my friends, is where the soft science gets hard. So there was a progressive decline in penile blood flow, both at baseline and at peak velocity, as the number of metabolic syndrome components increased. So, and this trend was significant even after adjusting for age. So essentially, those with metabolic syndrome had worse erectile dysfunction, essentially due to impairment of penile blood flow. And metabolic syndrome is also associated with hypogonadism. They found that those that had 3 out of the 5 components of metabolic syndrome had more than a 3-fold increase in the prevalence of hypogonadism. And if they had 5 out of the 5 metabolic syndrome components, that prevalence went up to 10 times the chance of having hypogonadism compared to those that did not have metabolic syndrome. And out of the components of metabolic syndrome, the major determinants that were associated with hypogonadism were high fasting glucose and elevated waist circumference. So again, related to insulin. Now, they also found that circulating total testosterone levels decreased, again, as the number of metabolic syndrome components increased. And we know that, again, because adipose tissue releases aromatase, which then converts testosterone to estrogen. So we know there's a lot of studies on erectile dysfunction, and that's great for men who are partnered. But the reality is that most men don't even realize they suffer from erectile dysfunction unless they're interacting with a partner and realizing that they're not performing as well as they'd like to. And this is why I so appreciated this next study, because this next study looked at men who were not partnered and were just relying on petting the one-eyed snake to get by. So this was a Chinese study that looked at whether weak masturbatory erections alone could be seen as a cardiovascular risk factor, meaning if they could not stroke it properly, did they have a risk of having a real stroke? And so they took 3 groups of men. The first group of men were young men between the ages of 18 to 40 who were not sexually active with a partner, and they were presenting with only a weak masturbatory erection, meaning they could have erections, but their erections weren't as strong as they wanted them to be. And then they compared them to 2 groups. There were 43 men who were in partnered relations and sexually active and didn't have erectile dysfunction, meaning they were normal. And then there was a third group, 179 men who were in partnered relationships, but they did have erectile dysfunction. And no one in this group had severe cardiovascular disease, diabetes, or high blood pressure. And then what was fascinating about this study is that they ran a lot of tests on these poor men. They did a brachial artery ultrasound, which they used as a measure of endothelial dysfunction. They ran inflammatory markers, insulin resistance. They did a glycosylated serum protein, which is essentially an average of glucose over a 2-week period. And then they strapped Holter monitors to these men's penises and checked nocturnal erection with a nocturnal penile rigidity test. And now, while the erections may have been weak, the one thing that was firm in this study were the results. Because what they found was that when it came to risk factors between the group without sexual dysfunction, the normal group, and the groups that did have sexual dysfunction, so either erectile dysfunction or weak masturbatory erections, there was no significant difference between the erectile dysfunction group and the weak masturbators in terms of risk factors. And the 4 most statistically significant risk factors were endothelial dysfunction, insulin resistance, high level of glucose, and poor nighttime erections. And when they adjusted for age, they found that the endothelial dysfunction through the brachial artery ultrasound, the high glucose, and the abnormal nighttime erections were independently associated with both erectile dysfunction and weak masturbatory erections. So this is important information to have because young men typically won't present to their primary care provider as a chief complaint of weak masturbatory erections. But I think it's important to think of this population as having the same risk factors as someone who has erectile dysfunction. And this is a wonderful opportunity to begin screening individuals for cardiovascular risk factors even before they present with frank erectile dysfunction. So Cialis, Viagra, all of these things are getting prescribed, but you must consider screening men who present with erectile dysfunction for diabetes and insulin resistance and other secondary medical causes before prescribing vasodilatory medications. Now, in women, the question is, does this phenomenon also happen in women? And remember, the studies are lacking in women. They're not as rigorous as in men. But I was able to find one study. Again, it was ironically an Italian sexual dysfunction clinic. So I'm not sure what's happening in Italy. I mean, they eat a lot of carbs in Italy, but they may not be having, they might be having sex problems there too. But this was a study that looked at clitoral vascular resistance, specifically by measuring an index called the clitoral pulsatility index, which essentially is it reflects a resistance to blood flow. So the higher the clitoral pulsatility index, the more resistance to blood flow there is. So these were 71 women who presented to this sexual dysfunction clinic with a primary complaint. The most common complaint was low sexual desire. And they ran several blood parameters, insulin resistance, cholesterol. But again, fascinating about this study is that they went ahead and did ultrasounds on their clitoral structures to measure the pulsatility index. And what they found was that women with obesity or metabolic syndrome had a significantly higher clitoral pulsatility index even after adjusting for confounders. And there appeared to be a stepwise increase in the pulsatility index as the number of metabolic syndrome components increased. And this data was significant even after they adjusted for confounders like age, smoking, and years since menopause. They also looked at the association between the increased pulsatility index and psychological factors like someone's degree of body uneasiness. And what they found was that increased pulsatility index was associated with not only decreased sexual arousal, but a higher degree of body uneasiness in especially parts of the body that were related to sexuality, like the womb or the breasts or the genitals. So clitoral vascular resistance is positively associated with metabolic syndrome, particularly insulin resistance, and there's correlations with this that can lead to certain body image concerns and sexual arousal issues. And this was something I read in the study that was interesting. It wasn't statistically significant data, it was just observational, but they found that in the women that had diabetes, there was a higher content of collagen in the clitoral structures compared to women that did not have diabetes. And this essentially represents smooth muscle degeneration at the level of the clitoris, which is really rather terrifying. So just like in men, women should also be screened for endocrine disorders when they are complaining of sexual dysfunction, and insulin resistance should be one of those disorders. And again, for women in particular, you also want to make sure you do things like rule out a prolactinoma, thyroid issue, make sure you do a pelvic exam as well. So before I get into infertility, earlier this year in March, there was this phenomenon in the media about something called Keto Crotch. And it was a big thing. There was a lot of talking about it. Keto Crotch was essentially these anecdotal stories of women who were endorsing that after they switched to a ketogenic diet, they noticed that there was changes in their vaginal odor. So first of all, there is no validated studies on this. I mean, I don't think anyone's going to do a RCT, with a sniff test as women are keto adapting. So I wasn't able to find any data. But if you think about it, in diabetes, we know that recurrent yeast infections, recurrent vulvovaginitis, this is a very common symptom of diabetes. In fact, sometimes it can be the initial presenting complaint in diabetes. And that is a complication of insulin resistance. So, I don't know really what to say about the subject. I don't think keto crotch is a real thing. I certainly myself would prefer keto crotch to a candida crotch. But I can tell you the internet had quite a field day when this was happening. So now that we've talked about sex, let's go ahead and talk about what happens after you have sex. You make the baby, or sometimes you don't. In fact, in 2010, there were over 40 million couples who were infertile, and men were 50% of the reason that this was happening. And when you think about insulin resistance, it's actually very important to recognize that glucose metabolism is very important for sperm formation and sperm motility and the ability of sperm to mature. In fact, if you look at the anatomy of a mature sperm, you'll find that there's glucose transporters all along the lipid bilayer to allow glucose to passively transport. The sperm have a mitochondrial sheath here where many important oxidative processes take place, and then connected to this fibrous sheath there's the principal piece of the tail, and this is where the most important glycolytic enzymes are located. And so it's these GLUT transporters that allow sperm to have the flexibility to adapt to various environments, like being in a uterus or your socks. And in diabetic rat studies, they found mice who had hyperglycemia. They had impaired GLUT9 transporters, and they suffered from low sperm motility and decreased fertilization rates. But when they corrected the hyperglycemia, they found that not only the sperm motility rates improved, but also the quality of the sperm did as well. On the human side, I was able to find one prospective case control study that looked at 160 men who had unexplained infertility, meaning their hormonal profiles were normal, but they had very low sperm count. And then they compared them to 79 men who were definitely fertile, meaning they had fathered children. And then they looked at various parameters, insulin resistance, hormones, cholesterol, etc. And what they found was that the fasting insulin level and insulin resistance was significantly higher in the study group compared to the control group. And it kind of sets this idea that perhaps insulin resistance could be a possible explanation for men that have infertility without any real etiology. So now with women and infertility, women get a lot of attention when it comes to infertility, and the causes of female infertility are really far and wide. But remember, men make up 50% of the reason as well, so it's half and half. And women's cause of infertility, again, many causes. There can be pituitary reasons, there can be medication-related issues. Actually, the most common cause of female infertility is polycystic ovarian syndrome, which is very much related to insulin. So again, polycystic ovarian syndrome is primarily characterized usually by ovulatory dysfunction, so there's either no menses or irregular menses, the presence of high amounts of androgens, so for example, excess body hair, and you may or may not have the presence of actual polycystic ovaries. PCOS is essentially insulin resistance at the level of the ovaries, because when there is insulin resistance, the high insulin levels, they signal the ovaries to increase the production of androgens, and then these excess androgens lead to increased weight gain in the adipose tissue, and then that adipose tissue worsens inflammation, and it leads to this vicious cycle. And in order to break the cycle, you have to reverse the insulin resistance, and in order to reverse the insulin resistance, you must eat low carb, because these hormones then play a role in fertility. So there's not very many studies. There's actually only 2 studies on the use of a ketogenic diet in people who have PCOS. This is the first study. It was a 24-week intervention, and they took 11 women with PCOS and they put them on a true ketogenic diet. They were only eating about 20 grams carbs per day, and only 5 of these women were actually able to complete the study. But they did, all 5 of these had improvements in their hormonal profiles, their fasting insulin, they all lost weight, and then 2 ended up conceiving without the use of any fertility medications. The other small study took 8 women with PCOS and they put them on a calorie-restricted ketogenic diet for 4 months. And only half of these women were able to actually follow the diet, and then 2 ended up conceiving without any assistance from pharmaceutical-induced ovulation. So granted, these are 2 very small, non-randomized pilot studies, but if you look at the numbers, 4 out of these 9 women were able to follow a ketogenic diet for about 6 months, and then they all were able to conceive naturally. So they had about a 45% success rate. And if you compare that to the average success rates of medically induced ovulation, it's fairly comparable, and it's certainly much more cost-effective than going through IVF. So before I conclude, I actually want to end with a brief history lesson, the history of Coca-Cola, because I think it's actually quite interesting and it's very much related to sexuality. So Coca-Cola was invented in 1886 by a pharmacist named John Pemberton, and he originally created Coca-Cola for medicinal use, but he wasn't a good businessman at all. In fact, Mr. Pemberton ended up dying from stomach cancer, hooked on morphine. And right before he died, he sold Coca-Cola to a business tycoon named Asa Candler. And Asa really wanted Coca-Cola to do well. He believed in the product, but Coke as a business at that time was not doing well at all. So Mr. Candler figured out a way to make Coke sell. He basically realized that if you take beautiful young women and you dress them up in Victorian dresses and you make them hold the Coca-Cola phallically, the Coke will sell. And literally overnight, Coca-Cola sales shot up. And if you look at this woman, I mean, this woman was a real showstopper for the time. I mean, clearly a huge slut. And they realized that this marketing strategy worked. And they continued to use this type of marketing as the decades continued. And Coca-Cola basically would sell this idea that this is the type of sexuality that you can have if you drink this product. And frankly, Coke has done quite well for themselves. They now sell 1.9 billion drinks per day. But I'm here to tell you that this is false advertising, because party's over. The reality is that 40% of Americans are obese, 50% are insulin resistant, and I can guarantee you they are not having the best sex lives that they could possibly have. So, in conclusion, I think sexual dysfunction is a possible sign of underlying insulin resistance, and patients should absolutely be screened as such. I think it's also important to remember that those suffering from metabolic syndrome could be suffering from significant sexual distress as well. I also think if men have unexplained infertility, insulin resistance should be one of the issues on the differential. And I certainly would love to see more studies in women and female sexual dysfunction as well across the board. I would also like to thank Nadir for giving me the opportunity to speak here. I also want to thank a couple of my friends that helped me along the way, Dr. Saslow, who helped me review the data, and then my comedian friends, Dan Gurin and Sammy Obeid, who helped me write a few jokes. And then a big thanks to several ex-boyfriends who I met along the way, because without them, I would have never been able to sublimate my frustration into an educational medical talk. So thank you. Thank you.